Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 19, 2018. Thank you for joining the presentation this month. Today's presenter is Dr. Elena Losina. She is the Robert W. Lovett Professor of Orthopedic Surgery and Biostatistics at Harvard Medical School. She is an internationally recognized investigator in the epidemiology and outcomes of musculoskeletal disorders. A few of her many roles: she is Director of the Policy and Innovation Evaluation in Orthopedic Treatments, or PIVOT Center, and co-director of the Orthopedic and Arthritis Center for Outcomes Research, or ORACOR. She directed the Statistical Center for Biomarkers Consortium, which was an international collaboration funded by the Foundation for NIH to establish the prognostic value of biomarkers in osteoarthritis. And she leads an NIH-funded multi-site project to conduct health policy evaluations related to surgical and non-surgical management of knee osteoarthritis. And today, she will present on physical activity and knee OA. Welcome, Elena.
Okay, hello, can you hear me?
Yes, I can. I was just going to tell you.
Okay, perfect. So thanks so much for inviting me, and we're going to get started. I would like it to be interactive, but I don't quite know how to manage interactions during the webinar. So I think, Hallie, if you can help me, or Kristen, you're more experienced. Otherwise, I will try to look at my screen if I see any questions. So now I need to understand how. Great. So I have an outline here, and what I would like to accomplish today a lot. We probably won't be able to do all of this, but I kind of developed this set of or deck of slides in such a way that it has several totally separate kind of novels, and I think we can stop at any time. So we're going to start with the definition of physical activity and its measurement. We will talk about validating commercial accelerometers in OA population, and then if we don't have any time and we stop there, I think we accomplished a lot. If we do, then I'll show you the project that we just finished about the quality adjusted years of life lost due to inactivity in knee OA population. And I think this is in the best possible world that how far we can go. If we still have time, we have a few bonus topics to go over. So let's start with what is physical activity. We'll turn to the source that I'm pretty sure every and each of us went at least once in the last decade. And it's actually, refreshing to see what's the definition of physical activity. So physical activity is defined as any bodily movement produced by skeletal muscles that require energy expenditure. So eating breakfast and brushing teeth, according to this definition, is physical activity. Physical activity encompasses all activities at any intensity performed during the 24-hour day, and it includes exercise and incidental activity integrated into the daily kind of lifestyle. How physical activity is being measured, we often hear this term of metabolic equivalent of task, or MET, is the objective measure of the energy expended by an individual while performing some specific physical activity compared to a reference. In reference, usually energy expended when sitting quietly. So by living, we are expending energy, and sitting quietly, is considered to be a reference point, and is being kind of estimated by quantitatively as 3.5 milliliters of oxygen per kilogram per minute. How do we assess physical activity? PA is a multidimensional construct, and it's no measure that can assess all facets of physical activity. So there are multiple ways we can try to assess physical activity, and the ones that we have been using for years, self-report, that can be done using questionnaires, frequency of certain activities, translatable into METs. There are tables that are available in multiple websites that tell us how many METs are biking leisurely, playing hockey, vacuuming, gardening. So every activity a person is doing can be translated into METs, and that translation has been done using the laboratory testing, really trying to understand how much energy people expend using different types of activity. That said, we need to realize that most of those validation studies and the kind of ascertainment studies are done in either in youth or younger populations. So when we're trying to figure out how many meds or elderly people with musculoskeletal conditions are using during various types of activity, we need to realize or recognize that those kind of standard translational studies into meds can be done in different populations. There are also validated scores such as PACE and Yale that had been developed specifically to ascertain physical activity among older populations, and they have the energy expenditure component that does the same purpose as trying to translate any activity into energy expenditure. They also had some summative indices that can be used when you're evaluating the efficacy of certain interventions. The interpretation of those indices is not very transparent because it's a number and it doesn't have direct interpretation how much physical activity is done, but as a difference measure ascertaining efficacy, it can be used as a comparative measure comparing different population groups. There are diaries and logs asking people, you know, how much or which activity they're doing, and there is direct observation that is not very feasible. And in the recent years, more and more we're using devices such as accelerometer, epidemiology, which measure steps per minute, average daily steps, weekly minutes of moderate and vigorous physical activity in sedentary time. Of course, if we're doing the national survey and looking at the self-reported physical activity, then 2/3 of our population is physically active. If we're going to use the study using the devices and getting objective measurement of physical activity, those numbers will be much less optimistic. So what I would like to take this opportunity is to help all of us to get on the same page and understand, you know, what are we measuring with accelerometry and what those counts and any other values that we're obtaining or reading from methods of several papers mean. So accelerometers measure acceleration, which is expressed in counts, in up to 3 dimensions. And acceleration can be translated into measurements of interest such as MVPA in sedentary time. Advantages of using accelerometers include accuracy, ability to capture a large amount of data, and ease in administration. And disadvantages include they are expensive, require technical expertise, programming, data handling, and they position sensitive. And they work best to capture the amount of activity. So accelerometers, as I mentioned, measure acceleration and static acceleration driven by the acceleration due to gravity. So in the graph that I hope that you can see, you know, there are 3 axes, vertical, anterior, and lateral. And traditionally uniaxial accelerometers use the acceleration due to gravity, so vertical. And the more recent accelerometers are now using all 3 axes, vertical, anterior and lateral, capturing not only kind of up and down movements, but also movements driven by vibration in more lateral movements. So the devices that measure acceleration in all 3 directions are triaxial. So when you're reading the paper or considering doing the study, calculating or estimating physical activity, always think about and take into consideration what device you are using or which device had been used in the paper. So triaxial devices measure acceleration in 3 axes, X, Y, and Z, and they calculate this acceleration using so-called vector magnitude, which is calculated as square root of sum of square root of counts across all 3 dimensions. So what is obvious here that if you're using 3 dimensions, that the number of counts will always be higher than if you're using only 1 dimension. So that's important kind of mental note to keep as we will talk about the thresholds that are being used to calculate physical activity. So what is count? Count is a measure of force, frequency, and intensity of accelerations and deceleration. And counts can be derived using the vector magnitude of acceleration from 3 directions. Again, the goal is somehow translate those counts to metabolic equivalent of tasks that we discussed earlier. And sometimes another meaningful measures of physical activity that we would like to get a connection between counts and meds are step length, which is a distance between consecutive placement of the feet, right, left to left, right. Stride length, distance between 2 consecutive placements of the same foot, and cadence, rate at which an activity is completed. So all these kind of concepts are often being used, and especially if we're planning the study, working with estimating physical activity, those measures are quite useful. So if we would like to use, for example, actigraph, which is the medical grade medical device calculating physical activity, the threshold for moderate physical activity using actigraph can be calculated using this formula, and often 3 hours, that's what is being used as the boundary or low boundary for physical activity. And so using this formula, 1924 counts per minute would emerge as the thresholds for vector magnitude, using estimating at which point the person is expending energy consistent with moderate to vigorous physical activity. If we're using not accelerometers per se, but trying to use more commercial accelerometers that do not always give us counts, so actually commercial do not give us count numbers because they're not transparent to the general population. So that's where we want to deal with cadence, and this is the connecting the step length and the energy expenditure. And in older population, you know, the correspondence with 3 METs is consistent with the speed of walking of 2.5 kilometers per hour or 4.1.7 meters per minute. This is the velocity, which is much smaller than the corresponding velocity for moderate to vigorous physical activity among younger population. And the reason is that people, when they get older, they work much harder, so they expend more energy to do certain tasks. So when we're working or thinking about studies in older population, it's important to use different thresholds and different boundaries. And the table below shows the difference between step length and cadence. So those who have a longer steps, they need to make fewer steps per minute in order to achieve those physical activity thresholds. And people, especially in kind of more aged population, sometimes making very small steps depending on whether they have concerns about balance or other physical status limitations. So they often make very small steps, and for them to make that kind of threshold for physical activity, they need to make many more steps per minute. So if the step length is 0.4, then it's 104 steps per minute. In general, on average, the step length, it's about between 0.6 and 0.7. So the next slide, again, points to the fact that when we're planning to do studies in physical activity using accelerometers, whether we're using the commercial or medical device, we would like to make sure that we are thinking carefully about the thresholds that we are planning to use to determine moderate to vigorous physical activity of sedentary time. For example, very frequently used thresholds from Troyana or Fredson, you know, presented in the first 2 lines of the table, but it's important to know that they are derived from uniaxial accelerometers. So if you're planning to use the triaxial accelerometer but would like to use those thresholds, so please use the only vertical axis counts and not all 3 counts, because you're going to get a little biased estimates. There are 2 studies that is useful to note, Barnett et al. From 2016 and Hall et al. From 2013. They used triaxial accelerometry and particularly worked with the older population. The age is 1775, not 753, is noted in the slide. I'm sorry, it's a typo. It should be period. And so that's where those thresholds of 1924, which is connected to 3 METs in elderly population, had been derived from, and also the walking speed of 2.5 kilometers per hour. The paper of Hall et al. Also kind of suggested that 3 METs is corresponding to 1.5 miles per hour, which is exactly pretty much the same thing as 2.5 kilometers per hour. So this slide shows 2 different devices. One is a picture of actigraph, which is the medical grade device, and another one is Fitbit Charge 2. which is commercial device. You cannot buy the medical device. You cannot buy Actigraph. You need to, do it for research in order to purchase it. It's quite expensive. It's about $250 per unit, and you also need to buy license and software, and you train personnel how to process the data. With Fitbits or similar devices, it's much easier. They're usually not as expensive, and the price varies from, up to $60 to $200. There are many shapes and forms and capacities, and they're very, very widely marketed to the population. So the question that we raised is, if we would like to do the study on physical activity that is scalable, we would like to make sure that, probably focus on commercial devices, because that's the only way for us to develop scalable interventions. And so when we looked at the prior validation study, many of them were focused on younger population, and only one study that we found was focused on older population, which showed that the Fitbits approximate steps rather good, but did not do any more information, did not provide any more information beyond steps. And that's generated our interest in designing the validation study in knee OA patients. In the next 3 slides, I would like to show the results of that study. We enrolled 15 subjects with knee osteoarthritis, and we asked them to wear 3 devices concurrently or sequentially: Fitbit Charge that is worn on the wrist, Actigraph that was worn on a hip, and Actigraph that was worn on a wrist. The reason, and sometimes they wore all 3 devices together, the reason we ask them to wear 2 devices, Actigraph wrist and hip, is just to make sure that we control for the side, because Fitbit is worn on the wrist. So this graph shows the correspondence between the measurements on 3 different devices on step counts, and the 45 degrees line is the reference line. So ideally we would like all the dots clustered around that 45-degree lines. And I think, this data suggests that the Actigraph, that Fitbit Charge approximates the gold standard Actigraph hip rather well. So that is shown on the slide that's on your left. And it's a little overstates those, so the Actigraph wrist overstates steps based on Actigraph hip, and the Actigraph wrist and Fitbit Charge have a little bigger spread, but the steps, I think, approximated are relatively well. The different story we're seeing when we're trying to compare the minutes of moderate or vigorous physical activity using those divides, again, the Actigraph hip is our gold standard on the first 2 graphs, and the last one on your right comparing the wrist and Charge. So that's where we see much less concordance that we hope, because the Actigraph hip, the data are derived from counts. For Fitbit Charge, the data are derived from steps, because the counts are hidden somewhere within proprietary software, so you can't really get a hold on counts. And it's shown that there is not that much correspondence between Fitbit Charge and Actigraph hip in measuring the minutes of MVPA. There is a lot of discrepancy between Actigraph hip and Actigraph wrist, and primarily because if you're using the same thresholds, which is kind of an important point to think about, then Actigraph wrist, based on the counting counts, produces much more counts just by chopping the salad or typing in a computer or flipping a page of the paper or simply eating breakfast. So all those counts are counted, and so that's why you see much more activity on Actigraph wrist. And the third graph is showing the correspondence between estimating sedentary time, and again, between Actigraph hip and Fitbit Charge. There is not a perfect correspondence, but there is a little bit of under evaluating of sedentary time based on Fitbit, but using wrist is not a good idea, because again, of all this extraneous noise that is being picked by Actigraph wrist. And the last slide that I think, I'm going to pause there, is just shows the summary table that points that how many hours of 24-hour time frame is spent on different activities where, if we look at active graph hip as the gold standard, so it shows that 46% of the time, people spent in sedentary time, spent about 6.5 hours in light physical activity, and I'm sorry, that about 10.9 hours they spent non-wearing, so we didn't ask participants to wear the actigraph or any devices during the sleep. It's about 6.5 hours they spent in sedentary time, another 6.4 hours spent in light physical activity, and very, very tiny amount of time they spending in doing physical activity. And these data are, relatively consistent between Fitbit and actigraph hip, although there is discrepancy between the sedentary and light physical activity. There is difference there, but actigraph wrist points to much more activity and even MVPA, so should be this information should be taken with great caution. So what are the take-home messages from the study that we have done? One size does not fit all, and use of accelerometer count should be aligned with the population and the study and the time of accelerometer. Actigraphs should not be worn on the wrist for research purposes for sure, or different set of thresholds should be used or designed specifically for actigraphs worn on a wrist. Commercial accelerometers approximate steps relatively well, and overall commercial accelerometers do not approximate MVPI well, should not be used to estimate total amount of moderate or vigorous physical activity, but could be used to estimate the efficacy of the intervention, determined as the difference in MVPA from the baseline to the end of the intervention. So let me pause there and entertain any questions you may have.
Thank you, Dr. Losina. I just wanted to reinforce for everybody that you can type in questions into the chat box activated at the lower end of your screen, and I will read them out loud for our presenter today. And while we're waiting for those, again, towards the end of the presentation, we'll flash up that survey. And while we're waiting for questions, I just wanted to say, as a Fitbit charge wearer, I thought that was very interesting. I was quite curious about the approximation and how closely they do approximate to an accelerometer. One question, sorry, I'll interrupt myself right there. Just to confirm, can you tell us what MVPA stands for? Is that moderate to vigorous physical activity?
Physical activity, yes.
Yes, okay. Oh. And that survey just came up, so for those of you, if you would quickly answer questions, or you can end the poll to clear your screen. One thing that this brings to mind, I know that for arthritis, people with arthritis, osteoarthritis, we know that physical activity can be quite challenging and is often very painful, or there can be, people may have fears of being physical activity or simply just struggle with movement. And you're probably familiar with Dr. Daniel White's research on step counts and looking at step counts around 6,000 for people with arthritis compared to 10,000 for the general population. That seems to be a pretty standard measure. How do you view this data that you have in your study that you presented? How do you kind of translate that to practice? How would you, how might somebody who is a physical therapist or someone take some of this information and make some recommendations to people who have arthritis or who are older in terms of using an accelerometer or, a Fitbit to help guide their efforts?
So I think there are several studies, seminal studies done by Dr. Messier and his colleagues suggesting that doing exercise, being physically active is beneficial for pain. And while we all recognize that, pain may be viewed as a barrier, that's actually not exactly accurate. We did a study on total knee replacement patients who had pain before and had very low level of physical activities. We looked at their pain after total knee replacement, which was very, very much relieved, but their levels of physical activity did not change much. So while pain is related to physical activity, there is a lot of it is kind of personality and previous habits. So I think, as clinicians, physical therapists, social workers working with people with osteoarthritis, we should encourage everybody to be physically active, because that's what will alleviate their pain. And if they need to take the tablet of ibuprofen to get going, that is totally worth doing it. But again, I think pain is often an excuse rather than a reason, based on the studies of total knee replacement recipients, where the same people with and without pain actually had similar amounts of physical activity or lack of such. In terms of step counts, I think, it's always good for us to have some sort of thresholds or targets. And I think 10,000 steps is for general population is an interesting target, which is not necessarily correlating well with the physical activity guidelines of 150 minutes or more. So, but I think that's a good threshold that people can use. I think, 6,000 steps for people with osteoarthritis, I think it's a good initial target, but I think potentially a more appropriate way of recommending is to increase the activity by 10% every week. So if somebody only is doing 3,000 steps in week 1, so maybe the next one is to recommend to see that they will get to 3,300, and the next week is to 37 or 3,600, and that I think is the way to help to move people forward, because I think 6,000, well, seems as a relatively good target. It's still quite low in terms of activity, and especially the major challenge between the steps and physical activity is people can make very small steps, and so that means that they are, energy expenditure is relatively low. And so number of steps is not the only measure of the physical activity. So I think, would like to encourage them to be and counting more than just steps. But I think counting steps is a good first step.
Thank you. I think that's really helpful. And certainly the behavior change aspect of being more physically active is a challenge. I think you're right about that. We have had a couple of questions come in. So one person asked, Carrie Costello asked, sorry if I missed it, commercial accelerometers approximate light physical activity well?
So again, I think it depends on what we saw is that the challenge in commercial accelerometers, and it was any accelerometers, is to differentiate between the sedentary and light physical activity components. And I think, what we found that one of the ways to deal with that is to use the commercial accelerometers with heart rate. So then you can distinguish between wear and non-wear very clearly. And you also can create a very clear algorithms how to estimate light physical activity. So if the person has a heart rate, that means that on accelerometer, that means they do wear it, and if the number of steps is greater than 0, that means that the person is moving per minute, and that's what we call light physical activity versus sedentary time when it registers 0 steps.
Thank you. And another question, Lisa asks, you mentioned that the threshold for moderate activity is 3 METs. What is the threshold for vigorous activity, and do you recommend a certain length of time that people should be active at a particular level each day?
So in the population of patients with knee osteoarthritis, all based on the studies that we have done and the data that we have looked, I think, we are lucky to encourage them to be engaged in moderate physical activity. So vigorous activity in people with musculoskeletal disorders, I think, is a rare occasion. I think, those who have musculoskeletal problems should definitely consult with their physicians before they engaging in extended vigorous physical activity, actually to any vigorous activity, especially if they had any devices implanted. So I feel that the focus should be on moderate activity in population with musculoskeletal conditions, especially of lower extremities.
And I know that we didn't get to it in your presentation today, but I recall from your list of agenda items, there was a note on there about the new physical activity guidelines. And this question makes me think about those and how those have evolved with this latest edition. Can you speak to that a little bit?
So let me just try it. So I will just show you one slide, which I think would tell us. So this is the slides where we can, so there is a, in a nutshell, the difference between all the new guidelines. The old guidelines suggested 150 minutes or more in bouts of 10 minutes or greater, and the new physical activity guidelines actually lifted that requirements to measure it in bouts. So now every minute count. And this is the graphs that you see are derived from the same data using two different criteria. The set of left bars are the compliance with physical activity guidelines for old PA guidelines for different age groups. So this is among people with knee osteoarthritis, 50 to 60, 60 to 70, and 70 to 80. And the right set of bars, it's the same groups of people using the same accelerometers, but just counting every minute of physical activity. So it's clear that the previous guidelines was a very, very kind of high bar to reach, and the compliance with physical activity guidelines was just in single digits in this population. So when we looking at the new guidelines, that we see that is a little more achievable. Still only about a third of people with knee osteoarthritis who is younger than 70 are reaching that a level of physical activity consistent with new guidelines, and it's about, still about 13% of older population. But the hope is that it's really now a little more achievable goal that that people will feel a little more kind of comfortable suggesting and recommending that it's a reachable goal, because now we have a third of people with knee osteoarthritis that is using it. And the very last slide is in the previous, because all PA guidelines, pain, we did not see much of association with pain, because again, it was so hard to reach that, regardless of the pain level, and that people just, did not do as much physical activity. If we look at the pain relationship with pain and the achievement in new physical activity guidelines, we do see some relationship, again, not extremely strong one. So obviously people with no pain at all, we have about 45% of them are reaching the physical activity consistent with new guidelines. And, when we're looking at the low, moderate, and severe pain, the proportion of people who reach that level of physical activity consistent with guidelines is reducing. But again, it's not just the pain. There are many people with the same level of pain have very different levels of physical activity. So I think the last recommendation is pain is an excuse, but not an actual cause of the low physical activity. And we as a community could do and should do more programs, encouragement to help people with knee osteoarthritis to be more physically active.
Thank you. I appreciate you sharing that. We're just over our time, but I would like to squeeze in one last follow-up question from before regarding METs, whether there is a maximum MET level that you recommend people with knee OA should stay below.
I think 3 to 5 is the reasonable kind of boundaries. Again, I think there are people with knee osteoarthritis that have been exercising for years and they swim, for 45 minutes per day. And I think there is nothing wrong with it as long as they don't go cold from 0 METs to 5, because I think that may cause additional injuries. That is, that's the consequence of this sudden huge amount of PA that would not be advisable.
I think that's reasonable. Well, thank you so much. I greatly appreciate your time and this wonderful information today. And I'll give a quick plug before we sign off for our January 16th webinar with Matthew Smith on Workplace Chronic Disease Self-Management Program. So once again, thank you, Elena, and thanks everyone for joining us, and have a very happy holiday.
Thank you. Have wonderful holidays.